You are following IPL this time?
थोड़ा बहुत.
Delhi is doing well.
बिल्कुल नहीं कर रहे हो?
नहीं, Delhi is doing well.
हाँ, for a change.
For a change.
तो normally नीचे होता है हमेशा. इस बारी थोड़ा अच्छा है, but I think Mumbai is on top at the moment. And Delhi.
But they have played a game more. They have played 6 games.
I'm following French Open also, वैसे.
अच्छा.
Because I'm a big Nadal fan.
So Nadal wins French Open.
तो he was semi-final में पहुंच गया नहीं. देखो आगे क्या होता है. मेरे को ये लगता है 2 मैच रह गए. सेमीफाइनल जीत लो, फिर फाइनल जीत लो, खत्म. I don't know how long we will be seeing these people. ये सब अपना रिटायरमेंट के कगार.
हाँ, बहुत ज्यादा मतलब Nadal and Federer.
He's been playing 2003-2004 is when he made his entry. और तब से हम उसके सुपर फैन है.
The same is with cricket actually. You have an era where no player can flourish till these 10 players are there. Same has happened in tennis also. मतलब there are only 2 or 3 Grand Slam winners. Yes.
So after Federer, Djokovic, Nadal, and for some time Andy Murray, fabulous 4 कहते थे. The others, amongst the various जितने भी Grand Slams in the last 15 years.
So one has been won by Wawrinka. अभी last वाला
11 है जो इन लोग चारों नहीं जीते हैं. उसके अलावा 4 हैं ऐसे जो बाकी लोगों ने जीता है. So Stan Wawrinka won the what do you call this French Open.
And this one अभी last भी तो US Open जीता ना this chap because everybody was chucked out.
Dominic team won the US Open अभी. इस साल का तो डोमिनिक टीम ने जीता है. आगे विनीता has come. Dr. Vinita.
Hi Dr. Vinita.
अभी हम तुम्हारी बात कर रहे थे.
आपका माइक म्यूटेड है.
Your mic is muted. So your mic is muted, Vinita. Unmute yourself.
No. I have to make her a co-host. Then she'll be able to. Just a second. Sorry. My bad. Now you can unmute yourself, Doctor.
Yes.
Hi, how are you?
Hi, Shubham. Big congratulations on success of Nelsicon. Your hard work was visible.
Everybody is, madam.
नहीं, you majorly contribute.
कह रही हूँ तुमको कि इसने बहुत मेहनत करी थी.
हाँ, दिख रहा था, heart and soul into it.
Thank you so much.
वो ना कहना नहीं पड़ता, वो दिखता है.
Thank you.
ये usually ऐसे ही काम करता है. हमारा जो कैंसर एकेडमी है, कैंसर एकेडमी also is he's taken it to the kind of space that we want to, and probably we will get to even bigger this thing.
Yes, bigger. I really like the moonshot, ground shot wala na. You were not there, Dr. Vinita. So they said that why are we talking of moonshots? This is one of our keynotes that when we have ground shots possible, when access is not available to healthcare in India at basic level, why are you trying to reach to the moon?
I agree.
It is called ground shot. Let us make efficient ground shots rather than aiming for what and what. Hello, I really liked it, and this was told by this fellow Kumar Prabhash. We had kept a lecture. Aam Aadmi. Yes, he was
that is so profound.
He said, let us do some ground shots.
A lot of these lectures I listen to later on,
I know, ma'am.
Because YouTube पे available है. मैंने सोनाली से बात कर लिया था meetings and more में. तो उसने मुझे बताया कि link share करने के लिए बोला उसको.
Okay. Yes.
Wonderful meeting. Meaningful meeting.
Yes, we found it. We try to not to keep the standard topics, but different topics because everybody has those.
Yeah, and that makes a lot of difference. Yes.
So last thing, Shubham, you are very inspiring.
Hello.
Madam, come on. I am among inspiring people. आप हो Dr. Vinita.
नहीं, आप बहुत inspiring हो.
Thank you, madam. Thank you. मैं बहुत छोटा हूँ, आपको पता है.
और फिर इसको 1 घंटे बात करेंगे.
Okay.
Meeting.
So has Sanjoy joined?
No, he's just joining. He's on his way back. So let us do this official thing. So just let me start.
We were trying to set a context to this, and what Shubham said was that he is one of the younger surgeon who's curious about radiation. So,
Yes.
and he said, "You are the senior surgeon." I said, "I am the senior surgeon who pretends to know radiation, but
Okay. So
radiation oncologists always have the grouse against surgeons कि वो हमें कुछ मानते नहीं है."
So good evening, everybody. Welcome. It's Wednesday 8:30, and it's the Cancer Academy time. Today we are moving on to radiotherapy from last week's surgical oncology, and to this time we will be talking about adjuvant radiotherapy for breast cancer. We have kept it broad speciality, what, when, and how, so that it sets the tone for radiation in breast, and we will be moving on to more specialized topics like partial breast irradiation and
Okay,
probably
great. Thank you.
hypofractionated radiation and stuff like that. But today is a broader topic which can help everybody, our surgical colleagues, medical colleagues, radiation colleagues, and it will set a tone for the coming 3-4 weeks, where we'll do subsequent lectures on breast irradiation. And we have with us Dr. Vinita Goel, who is the Associate Director for Radiation Oncology at Mac Shalimar Bagh, and she's a very experienced radiation oncologist. And along with her, we have our co-host, Dr. Geeta Kadyaprat, who is a very renowned breast cancer surgeon. And for today's talk, we actually have Dr. Sanjoy CHatterjee from TMC Kolkata joining us, but he's just a few minutes late. So we will start some discussions with Dr. Vinita and Dr. Geeta in the meantime. And I will request, because we don't bite and we are very friendly, I would want people to put in messages. We will really read them, and we will try to, before Dr. Sanjay joins in, we will try to, give you an overall perspective how radiation is, and how radiation oncologists and surgical oncologists coexist in a cancer center, and what are our challenges, how do we communicate. So let me start with Dr. Vinita. Madam, you have been in this field for, I don't know, I don't want to reveal your age, but I'm sure that you have been in this field for more than how many years I am practicing, but still. So what is your grudge with surgeons? Is there a grudge? For first question, is there a grudge with surgeons? We are talking about breast cancer, and if there is, how do you think we can improve?
And before she answers, let me tell you, she's got her exceptions also.
And her husband is a surgeon,
so the exceptions are far and few, but I actually hold a lot of grudges against breast surgeons.
Yes, so, madam. Just getting the so for starters, this thing is live on YouTube and it is being recorded. So we are very happy, madam, that you have come on public platform to accuse us, but we are happy to take all accusations. Yes, madam, we'll start.
So some of these are real. So I'm sure you cannot challenge me on that.
So you feel that there are some which are not real, actually? Then half of our job is done.
So my biggest grudge is not having a cross communication right in the beginning when a patient is diagnosed with breast cancer and you all start the treatment. For example, if you see early breast cancer and you feel that the patient is operable and the patient is straight away taken up for surgery, we as a radiation oncologist never get to see these patients in the OPD. What we get to see is only the post-operative status of the patient, histopathology report, and if MRM is done, then we see a bare chest wall, and it is hard for us to make out where the initial tumor must have been. If we have a background of the location of the tumor, whether it was superficial or deep, whether there were any skin changes, pudy orange, etc., I'm sure our job, our radiation therapy planning would certainly become better.
Okay.
So I remember having an instance, one of my colleagues, he was simulating a patient who had undergone mastectomy, and the scar was a little, raised and quite hill-shaped scar was there. So when I just peeped into the simulator, I said, "What kind of scar is this? This looks abnormal." So, he casually said, "This patient got operated outside. So maybe some inexperienced surgeon." I was not satisfied. So I picked up her PET scan, and then I found that the tumor was actually infraclavicular in location, And I understood that the surgeon who had done MRM had done a good job and probably tried to encompass the tumor in the mastectomy scar. And that is why the scar was not a traditional, horizontal scar of the mastectomy. I wish this information was shared with me earlier rather than, me digging out this information, because I suspect that some of us may not pay attention to these finer details. Some of these patients who are given neoadjuvant chemotherapy and then they get PAT CR or very good responses, and then they come back for radiation therapy. And then I start searching for some clinical diagram made by the surgeon to understand how big the tumor was actually pre-chemotherapy, in the pre-chemotherapy time. Was it really an inflammatory breast cancer by clinical means? I have to really dig out that information. Sometimes I get it, sometimes I don't get it.
Okay.
And my biggest grudge is oncoplasty. It has made life very difficult for us as radiation oncologists. I'll give you an instance. A patient came to me for simulation. She had undergone a breast conservation surgery with oncoplasty somewhere outside. There was no clinical diagram. She had some imaging done prior to surgery, which was submitted to the TPA. And when we simulate, and then there was an oncoplasty. So the scar on the breast was not guiding me about the location of the tumor. And worst, there were no surgical clips. We were completely lost as to how to give and where to give radiation a boost, because there was no cavity as such also. So the patient could, see that I was in dilemma. And she said, "Doctor, wo kuch na bol rahe the 9 o'clock, 10 o'clock. Does it help you?" I said, "Yes." Shubham, there are several gaps in communication. I would say that I'm very fortunate that I work with very good surgeons who are very open-minded, who share a lot of information. Still, there are gaps.
So
I would also give you a chance, Shubham. You can also take out your grudges against radiation oncologists.
No, madam. I dare not have grudges. I have Dr. Geeta to vocalize all that for me, and she does it for me, so I have no issues. But I think we have Dr. Sanjoy joined with us, Dr. Geeta. So I would like you to introduce Dr. Sanjoy, and then we can begin our discourse for today, and then we'll definitely respond to Dr. Vinita's.
Vinita at the end, yes.
Allegations, you want to call them allegations?
You may call them.
So we will do it.
Yes. Okay.
Okay. So it's my pleasure to invite Dr. Sanjoy CHatterjee to this Cancer Academy. So, he is a very underutilized resource in this times of webinar. I don't think many people have heard you, Sanjoy. Probably you deliberately kept out of it, but I was very glad when you accepted our invitation, because all those who are here today are very lucky to hear this gentleman who's an excellent orator. And there's a lot of body of work behind him. There is a lot of things that he does, and he is a prolific writer, meaning you'll find a lot of his publications. I always, whenever we go to a conference, we are presenting data from everybody else's, and this gentleman is presenting his own data, which is just so phenomenal. And I think, that is one bit, which, we have not been able to catch up on Sanjoy, and Sanjoy does a very good job. And when you hear him today, you will know how fantastic he is. So just to give you a background of Sanjoy, all those who don't know this about this pearl who exists in the radiation oncology field, that he's a consultant at Tata Memorial Hospital, and he did his MBBS from Kolkata Medical College, and he has a lot of international exposure. I think that opens up your mind quite a bit. And for all the postgraduates and the oncology trainees on here, if you get a chance to get exposure abroad, don't even flinch. Even if it means that you have to spend the last penny of your saving to go there and get that kind of experience, just opens up your mind. He has 10 years of international exposure working in places like Nine Wells Hospital in Dundee. I'm sure he had a opportunity to interact with Jayant Vaidya also, because he used to be in Dundee at some point of time. Beatson Oncology Center in Glasgow, and Western General Hospital in Edinburgh. So he has his CV does read like a dream. So I will not go into all the publications that he's put forth, but here is your opportunity to interact with this fabulous gentleman, Dr. Sanjoy CHatterjee, and he is going to speak about the when, how, and what of radiation in the adjuvant setting in breast cancer. So over to you, Sanjoy.
Dr. Sanjoy, you are a co-host. You can control your audio and video, and you will be also be able to share your screen, sir.
Thank you so very much, Geeta, and the team in Cancer Academy. It's an absolute pleasure to come and see. We have deliberately been and consciously been sort of low-key at the time of the pandemic and over the last couple of years. I really don't want these webinars, but when requests from friends like you, Geeta, and I can see Vinita over there and the others come through, I better say yes, because I would learn much more interacting with you rather than sharing what I have learned. Well, when Geeta called me, she said that she wanted to speak about wanted me to speak about accelerated partial breast radiotherapy, or something like intensity modulated radiotherapy in breast cancer, etc. However, I felt that under the current circumstances, it is possibly best that I revisit the basics of radiotherapy, revisit what radiotherapy is all about in breast cancer. Let's not forget what it can or can't do, and then possibly look at the future, take a peek as to what can happen with radiotherapy and what has happened, which is topical. So I just wanted to know, how long do I have? Is it 20 minutes, half an hour, 30 minutes?
No. So, sir, this is an educational one. There's no time limit. We are on a paid Zoom subscription, so there's no time limit. But anywhere between 30 to 40 minutes would be good for us. So it leaves us 10 to 15 minutes to interact. But if you feel that it is getting too long, or you want to cut it short to 20-25 minutes, it's totally your call. Totally your call. I know it's a big topic, adjuvant radiotherapy, but however you want to go about it, sir.
Right. I have the privilege of talking on adjuvant radiotherapy, and I can talk all night on it. But
yes, I'm very sure.
I think let's say that once you get bored, let me know. We will cut short.
Sure, sir. Sure.
So I will try and share my screen such that you all are into this. So share screen. There we go. And then the presentation. So I understand that you have mainly surgical oncology sort of trainees, and
we have a mixed bag. And actually today there would be more radiation oncologists today. I feel. I'm not sure.
Okay, yes. Brilliant. Okay, so basically, adjuvant radiotherapy in breast cancer. The picture on the top is of my hospital, which it was about a year and a half back. It's just replicated in that, the hospital now has a phase 2, which is exactly looking the same as the phase 1. So just put two pictures side by side. You'll have the current Tata Medical Center hospital in Rajarhat. I have the privilege of working in this hospital from the inception, and I'll share with you some of the insights as to how we set up things in Tata Medical Center, such that trainees can then think about how they want to go ahead setting up their practices, and how we sieve the evidence from what there is in the literature. So look, we are going to talk about changing paradigms. We're going to talk about, what has changed. But, to know that, we need to establish ourselves specifically on what we know. What is it that we know about whole breast and post-mastectomy radiotherapy, when to choose to treat, what is changing, and do we have good quality data? What about internal mammary chain radiotherapy? And, partial breast radiotherapy, IORT, external beam radiotherapy, especially when we spoke about Nine Wells Hospital and Jayant. Yes, of course. When I was training as a specialist registrar, Jayant and me, we were doing the target study. Unfortunately, we know what the results are, especially with the Lancet publication 2020. And the complex treatment with using inverse planned approach, we would actually talk about that as well. So there's a lot to cover, but honestly, we don't want to cover everything. I think it's impossible to cover each and everything in certain depth for these. I'll start off with the very simple thing that I understand. You know, in with anything in life, it is a balance between good and bad. In radiotherapy planning, it is not any different. Is that, you know, what we tend to do is we want to increase the tumor control probability whilst reducing the normal tissue complication probability. So for the surgeons, you know, we as radiation or clinical oncologists, we're actually very simple people, not flamboyant. We want to just make sure that the tumor is controlled with less normal tissue complication. And that is what we call as the therapeutic index, or the uncomplicated tumor control probability. With this in mind, let's try and sort of look at the evidence that we actually base our radiotherapy on for. So radiotherapy has been used in breast cancer for adjuvant therapy for quite some time. What is important for us to understand is that think of any other cancer that you are treating, in which if you look at the graph on your left, you can see that conservation surgery actually causes a 25% chance of any second tumor recurrence at the end of 10 years. So, you know, this is around 35% chance of tumor recurrence at 10 years. And look at this rate, breast conservation surgery plus radiotherapy, the rate reduces to 19.3%. So it's around a 40 to 50% relative reduction in breast tumor recurrence or any recurrence of breast cancer. Now, what this is also important to understand is that, you know, okay, it reduces recurrence, it's fine. But what else? For every recurrence, every local recurrence or any recurrence that it reduces, it actually improves survival. It improves breast cancer survival, and it improves all-cause death as well. So a local treatment, radiation, X-rays being used locally in the breast and or the SCF or even the chest wall, which we're going to come down later on, we can see it's not just a local effect that it's having a systemic effect in that we are reducing death. Now, there must be more into it, isn't it? If you've got a local treatment reducing death, there must be more into it. And let's try and see if we can dive a bit deeper into what happens with breast radiotherapy. Now, I'm sorry for this this slide. It is actually wrongly formatted, and I don't want to reformat it now. But you know, this is the data from post-mastectomy radiotherapy. What you can see is basically, you know, there's a similar benefit in post-mastectomy radiotherapy, especially in the node-positive post-mastectomy radiotherapy patient. Even if the patient has one node positive, there's a significant benefit not only in local control, but also in all-cause death. However, in the node-negative post-mastectomy cases, things become a bit more complicated. There you go. This is yet another example of the local regional effect of radiotherapy. You can see with the node-negative cases over here, the benefit is pretty limited, whilst in node-positive cases, the local regional benefit is often translated into the breast cancer mortality benefit. And for what we say is for every one local regional response or local regional recurrence that we save, we actually save one breast cancer mortality. So if for every 4 local relapse that we save, we actually save one life, one patient with mortality. So this is the magnitude of benefit of an adjuvant treatment. Now, once we think of the magnitude of benefit and the data, you know, these are 20 years, 10 years data that we are looking at. Obviously, we have to think that, you know, at 20 or 10 years back, we didn't have IMRT. We didn't have all these sophisticated tools, but, you know, the benefit is on mortality. So what were our colleagues doing better over the last 10, 15, 20 years that we should not let go? So that brings us to the basics of radiotherapy. So in general, the indications for radiotherapy is that post-mastectomy for T3, T4 tumors, 4 or more nodes positive, if someone has neoadjuvant chemotherapy, especially for locally advanced tumors, or for after breast conservation surgery. Now, there could be a bit of debate on whether lymphovascular invasion post-mastectomy, grade of tumor, which is grade 3, 1 to 3 node positive, are these indications for radiotherapy? And we'll discuss about, you know, some scoring system, something that we look at to try and get a better idea as to who to irradiate post-mastectomy. Now, with a gross idea, especially for the candidates, for the colleagues of ours who are students, with the gross idea that yes, these are the patients that we irradiate, let's try and see as to how we do it. So basically, in patients with breast cancer, we have either a conserved breast or a chest wall that we irradiate. And there are certain guidelines that have come up now, especially the estro guidelines that most of us follow, as to what to irradiate when we tend to irradiate breast cancer. So what is the superior level, or how far up do we go to irradiate? How do we contour the supraclavicular fossa? How do we contour the rest of the chest wall? And deliberately, I've actually not discussed these in my presentation because I don't want this to be a technical presentation. Rather, we all know that the URTC, the ESTRO guidelines are available online, and we can actually look at them and get our planning parameters sorted, especially the radiation oncology colleagues. Then what? Well, like I said, we talk about concepts. The concept of breast cancer radiotherapy is that we have a straight posterior edge. So, for non-radiation people who are listening to this, for breast radiotherapy, what we tend to do is we tend to direct radiation, which is high energy X-rays, from the two sides, and we call them as tangents because the central axis actually, well, the center of the beam actually falls as a tangent. If you look at this and this contour, this beam falls as a tangent on this or this, and that's why we say that we use two tangents to treat breast cancer. However, the rule is that if we use a beam usually would diverge. To prevent divergence of that beam, we want a straight posterior edge such that we don't want low dose to affect the rest of the lung. So if there is divergence of the beam from this side, there is divergence of the beam from this side, we will be treating more lung. So we try to avoid that. Exit beam from this side, if we are treating left-sided cancers, if there's divergence, a lot of the heart can get damaged. And that brings me to the first slide that I showed you, that it's always a balance between what is good versus what is bad. And we don't want the bad things like pneumonitis, like cardiac effects taking over the benefit of breast or chest wall radiotherapy. The other issue that we have to think of is that it's not just this, it's a three-dimensional process. We also have to have a straight superior edge such that the beam that comes in to treat the supraclavicular fossa actually does not overlap with the beam divergence from the tangents. So, there are beams that are coming in to treat the chest wall. There are beams that are coming in to treat the supraclavicular fossa, and they should all meet each other straight away without any significant overlap, because overlaps will cause damage to the structures over here, including the brachial plexus, which follows this area. So please make sure that your technique that is used actually does involve a significant match or a straight line match of your SCF and your superior edge of the tangents. Now, this is the current three-dimensional contouring. I'm totally unaware as to whether three-dimensional contouring, especially routinely for all breast cancer, is required. We at Tata Medical Center do not routinely contour all breasts unless they are within a clinical trial, which we'll talk about, which we are conducting. However, if you're doing it, you're not doing anything wrong. So there have been technical advances. So, I said that these trials, the EBCT-CG overviews, are actually 20-year reports. Now, for a 20-year report, you can imagine there was no 3D conformal planning. I mean, most people were treating using cobalt and also linear accelerators without much of a planning, a 3D planning available. So virtual simulation has actually helped us understand what we are treating, how much heart we are treating, and become more safe doctors. It has not helped us to improve the overall efficacy of the treatment, but it's helped us to become more safe and also improve cosmesis. So basically, it's something called step and shoot IMRT or forward planned IMRT, which some people use, including us. I'm sure there are many across the country who use it. And we tend to use it because what we tend to do is when we are treating this area, we want a uniform dose across this area without much of a dose variation. And that brings us to that gives us a better cosmesis. So this is the benefit of the technical advances. The other technical advances that we've had, I'm going to talk as we go through, because it's going to be difficult for me to explain the advances, but they could actually reduce the heart and the lung doses further, and intensity modulated techniques have been piloted across especially certain apical centers to do what is called a simultaneous integrated boost, which we're going to discuss later on. One of the problems with a teaching session in Zoom is that we can't have interactive questions, but I'm very open. If there is anyone who writes on the chat bot and wants a question to be answered on any of these that we've covered, because these are the very basics, please let us know and we can always discuss. So team, are we okay to continue?
Yes,
or do you want to ask anything?
we are very good to continue, sir. And I'm following the chart. If there's any question, I'll interject in between whenever we are between slides. Don't worry.
Thank you, Dr. Garg. So this is yet another example of how uniform, sorry, I have a bit of food in my mouth, just walked in from hospital, sorry. This is a uniform dose distribution that you can see, which actually makes cosmesis much more easier using something called forward planned IMRT. Right. We Tata Medical Center runs what is called as the Varian Image Guided Radiotherapy course, or Varian IGRT course. And in the Varian IGRT course, I do discuss about IGRT in breast cancer. And today, I actually asked, we had a session where I was interacting with 3 new centers that are commissioning breast cancer radiotherapy. And I asked, would you usually give a tumor bed boost? And the answer from all 3 centers was no, we don't give a tumor bed boost. Now, for people who are trainees, my humble submission is that please don't forget to give a tumor bed boost in patients with breast conservation surgery, especially in patients of our country, because it has shown that there is around a 35% improvement in breast tumor control, which is obviously statistically significant after giving tumor bed boost. Yes, the improvement is more in the young. However, this is Western data with screening population and screen detected population, and also the fact that you can see there is a significant improvement if you give boost, especially in the younger patient, especially in the presence of DCIS, and also a trend towards improvement if you have a higher grade of tumor. It just proves that patients who are not screen detected, and the majority of our patients in this country are not screen detected. Patients who have grade 3 tumors, again, majority of our patients have grade 3 tumors, and we do have a younger population of patients. In these group of patients, we must not miss the in-breast, we must not miss the tumor bed boost. Now, what is a tumor bed boost? Well, basically, breast cancers, after our surgeons like Geeta and Dr. Garg, once they operate and take the tumor out, what happens is it has been found that there's a cavity that's left behind, and the recurrences actually happen more or less within 2 to 3 centimeters of this cavity. So there must be some humoral effect, some local effect, and that it was the hypothesis behind giving tumor bed boost. And of course, the Bartling paper, which was later on published again back in 2016 with 20-year data, it again showed that boost should not be discounted. Now, how do we delineate tumor bed? How do we understand what a tumor bed is? Well, look, if there is a seroma, if a patient has had surgery and there is a seroma, we often find seromas in our patients if they come in straight after surgery. But given that majority of our patients have locally advanced tumors, and many of them actually have adjuvant chemotherapy, we tend to miss them because the seroma gets observed and the tumor bed collapses. So hematoma, seroma, they get observed. More than that, how do we differentiate between a tumor bed if there is no marker over there? And there's been many ways of looking at it. Some people use ultrasound, some CT scan, but the best and the most tested way, which is established across the world, and I'm really happy that it happens in India with surgeons like Rosina and Geeta doing it, is that they place the tumor bed clips, and that is what helps us delineate the tumor bed. and then we can boost that tumor bed after completing the whole breast radiotherapy. Now, this is yet another example of seroma. And the problem is the seroma changes over time. So if it is a long treatment, like 5-week treatment or 3-week treatment, you'll find the seroma collapses. So what do? Do we change our bed boost? And more importantly, with the current oncoplastic procedures, there's significant mobilization of the breast tissue. And with the breast tissue moving, we really want to know where the tumor bed boost is. And these seromas are often something that we don't find. Therefore, unless there are tumor bed clips that they put, it is impossible for us to direct the tumor bed boost. The bottom line then is that, for surgeons, please, surgical trainees, please do put in a clip. If you forget, you're going to prevent, or you're going to be the cause of recurrence of tumor in 35% of cases. And for radiation oncologists, if you forget to boost, you are going to be the cause of tumor recurrence in 35%. Right. Coming back, so basically, we talked about tumor bed boost. Now, when we have tumor bed boost, how do we boost? I showed you that, we have tangents, we have beams shining in from these two sides. How do we boost this area? Well, the easiest way to boost is actually, you can see that there's a wire placed over here, and this wire over here is basically, I'm sure, can you see my arrow moving? I mean, Dr. Garg, is my arrow visible?
Yes, it is visible. It is visible.
So you can see that there's actually a bolus on the scar that has been put, a wire on the scar that has been put, so that we understand where the tumor bed boost needs to be given. So there's a wire over here, and we are placing our beams now coming in from here, what we call as electrons, because we don't want the beams to be too penetrative. And then we can boost this area, because if it is too penetrative, there's going to be an overdose to the lungs. So that's why what we want is we want a system whereby we can delineate the tumor bed. And then if we can delineate the tumor bed and see the tumor bed properly, what we tend to do is we tend to use what we call as mini tangents. And I'll tell you what mini tangent is. It's a study that we did way back in 2013, 1 or 2 years, 2 years into our practice. And we thought, what we are doing with electrons is good, but is that optimal? So what we tend to do is then, apart from having the tangents for the whole breast, we had smaller tangents, like, treating just to treat the tumor bed. So, rather than treating the whole breast, it's a small field that we're using, just coming from this side, using X-rays to try and treat the tumor bed. And what we found is that compared to electron boost, we had better conformal therapy, or, as surgeons complain of blood loss, lesser blood loss. So, if we have lesser damage to normal tissues, we say it's more conformal. So we have more conformal therapy using our tumor bed boost with mini photons. Now, this is an example of mini photon radiotherapy. So basically, we are using, rather than treating the whole breast, after we complete the whole breast treatment, we don't bring in electrons from outside to treat all this tissue. So to treat this area, the electrons have to treat this area, this area, this area, all this area, because we are shining the electrons from this side. Whilst if we are treating with mini tangents, we are over treating on the sides of the tumor, and we are treating the tumor bed. Remember, the sides of the tumor being treated may not be a bad thing, given the fact that we said the tumor bed, if we have an extra dose over here, it may actually be better rather than worse. So this is what the concept of photon mini tangent boost is. And this is a simple study that we did way back in 2013 and established our practice. A couple of slides on something that most of us do. Or don't actually, because topical. Many centers across the world have started using internal mammary chain radiotherapy. But let's try and see into the data. So if I go back to this, if I'm treating internal mammary chain, I would be treating this area. Now I told you that we're using photons. So we're using this. We are sparing the internal mammary area. Now, if I have to use and treat the internal mammary area, the problem is that I will treat a lot of heart, because, you know, if I have to treat this area, the heart is over here. There's strong data to suggest that there is survival advantage. And let's look at the 3 randomized controlled trials that have come out with
Sanjoy, I
internal
think there is
memory
a
or, you know, regional nodal radiation plus minus
So your audio is not clear. I think there's just a
radiotherapy.
connection issues.
The only study amongst this supraclavicular radiotherapy, the other 2 studies, which and the URTC study, yeah, Geeta? Hello, is this any better? Hello?
Yeah, it's better.
Better.
It's better, definitely better.
Yeah.
Okay. So I'll try and use the headphone then. I mean, am I audible? Is this better?
No, it's
Better.
yes. I think there was some connection issues rather than your audio issues, because we could hear you well. It's just that there was a big lag.
Okay. Well, all I tried to say is that, you know, when we tend to treat the chest wall, we tend to spare the internal mammary chain area, which is this area, because, you know, we are treating with tangents coming on from these 2 sides. So we are sparing the internal mammary chain area. So in order to treat the internal mammary chain area, we have to focus beams coming in from here, or maybe open the tangents such that we are treating from here. What that means is that the heart gets along a higher dose. So in order to convince ourselves that internal mammary chain radiotherapy is better, we need data that shows that there is a survival advantage, especially by giving internal mammary chain radiotherapy, given that the heart is getting a lot of dose. And the studies that have actually looked at the internal mammary chain radiotherapy versus no internal mammary chain radiotherapy, the only study that's looked at that is the French IMN study, because that actually randomized between IMN versus no IMN in post-mastectomy patients. SCF radiotherapy was not something that was used to randomize. But the other 2 studies used chest wall radiotherapy plus minus nodal radiotherapy with internal mammary chain radiotherapy. Now, SCF or supraclavicular radiotherapy, as I showed you at the beginning, is much more easier because it is something that we just match on to our tangents. Morbidity is much less. But the minute we start treating the internal mammary chain, there seems to be more morbidity. So let's look at the sort of data over here. These curves are pretty close together between regional nodal radiotherapy, and we are talking about overall survival curves. These are all survival curves. The curves are very close together, so there's not much survival advantage in giving internal mammary chain radiotherapy. However, if we look at the difference in the studies, you know, we can see that, you know, the biggest benefit came from the medial tumors. Of course, if you have an internal mammary chain that is affected, it's more likely that a medial tumor is active. So medial tumor, which is and patients with N1 disease actually benefited more in the French IMN study. In the MA20 and the URTC study, we found that, you know, there was not much difference, and even the ER positive, well, I think this is a chance finding. However, there was not much difference in the factors that would actually predict which patients to treat and which not to, and that's mainly because we are treating the supraclavicular fossa as well. And we showed you with the URTC data that post-mastectomy, if there's one node positive, we do need to treat the supraclavicular fossa because there's a survival advantage. So supraclavicular fossa, if taken out, if you just look at the French IMN study, the disease-free survival benefit was not much. So that includes the local regional recurrences. However, with supraclavicular and internal mammary chain radiotherapy, the disease-free survival benefit is significant. Hence, you know, the thought process is that use internal mammary chain radiotherapy if you have to. Our current protocol in Tata Medical Center is that we tend to treat internal mammary chain only and only if there's an internal mammary node. And believe you me, there are a significant number of our patients at the time of staging or at the time of planning scan that we find do have internal mammary nodes. So yes, it is only something that we treat if there is a node that is present in the internal mammary chain. This is a summary from meta-analysis by Nielsen and also another report by Henson, and they also sort of agree with what we've just discussed and say that, given the technical issues, the data is really not very strong enough for us to say that internal mammary chain radiotherapy must be given for all patients. Right, that brings us, that brings us to the indications of radiotherapy and what radiotherapy to give. Now we are coming to a topic that over the last 10 years, India has evolved into, or India has adopted. And the topic is very close to my heart, a topic of fraction size sensitivity of breast cancers. Now for the surgeons, why am I getting this excited? It's because, you have a one-step procedure, or almost usually have a one-step procedure, unless you want to clear the axilla after a sentinel lymph node biopsy. It may be a two-step procedure then, but we as radiation oncologists, we tend to bring our patients on and on over a period of 5 weeks, 6 weeks, and so on. Now it actually affects patients' lives, isn't it? Okay, I've got to go there and have the treatment for over 6 weeks. And for that, if we try and see if we can reduce the treatment time, is there a benefit? And we are lucky that, in breast cancer, the benefit seems to be tangible. Why is that? Because some cancers respond to fraction size. What I mean by that is that, if there's a cancer A and there's a cancer B, and we are treating one cancer at 2 grays per fraction versus another cancer at 3 grays per fraction, a cancer which is like breast cancer or prostate cancer would usually respond to the 3 gray per fraction more than a 2 gray per fraction. So it becomes absolutely, important that we understand that breast cancers respond more to a high dose per fraction. Then why is it that people have not been using high dose per fraction over the last so many years? It's mainly because what people forgot in the initial experiments that they did is that they gave a high dose per fraction, but they did not optimally reduce the total dose that was given. So for breast cancer radiotherapy, or for any radiotherapy per se, what we have to think about is a dose per fraction as well as a total dose effect. Now, if we don't reduce the total dose appropriately, then obviously the normal tissues will start dying more. And the UCP effect, the uncomplicated tumor probability effect, is going to be spoiled. So that is why when Ellis's iso effect formula was used back, and the Manchester group was treating using 45 grays in 15 fractions, there was a lot of toxicities. And UK, which were the pioneer of hypofractionation, had the committee called RAGE that was formed. Now RAGE is a committee that we think of, or people are actually very angry, and that's why it's actually a committee that was made hypofractionation, and there was worse cosmesis. So RAGE committee did an introspection and came up with certain recommendations that stop hypofractionating. However, after that, slowly back in the 1990s, again there were these 3 studies that used moderate hypofractionation. By moderate, I mean a dose of 2.67 grays per fraction, a dose of maximum 3 grays per fraction, and we now know. And these are 3 established studies that have proven that, in all sets of tumors, hypofractionation using 40 grays and 15 fraction seems to be at least as good as a 25 fraction 50 gray regime. And the cosmesis seems to be better using the hypofractionated regime. Now, is it applicable to our Indian patients? If we look at the data from the START-B study, yes, it's applicable to the younger patients, the node-positive patients, the grade 3 patients, and the adjuvant chemotherapy patients. What is very, very important for you to look at is that look at the hazards ratio and look at the forest plots over here. So basically, look at the age less than 40, and you can see, although the confidence interval actually is wide, you can see that the center is over here favoring hypofractionation. For younger patients, favoring hypofractionation. for node-positive patients, favoring hypofractionation for grade 3 patients, and also favoring hypofractionation for adjuvant chemotherapy patients. Now, as I said, it was an unplanned subgroup analysis, and I'm not by any chance saying hypofractionation is better, but at least we can conclude it is at least as good as fractionated radiotherapy. Even if it is as good as fractionated radiotherapy and the cosmesis is better, we know that's actually doing them a lot of favor. Well, the question, there was a lot of criticism. I still remember the email communications that we had with many of our esteemed colleagues as to why on earth are we starting hypofractionation, especially in India, where we have less screen-detected tumors. And we were relieved to publish our data back in 2016 to say that, yes, hypofractionation is not only effective, and we were one of the first to publish the data on 1,000 patients to say that hypofractionation is effective across groups in the non-screen Indian population. And this is irrespective of the big tumors, that whether they have neoadjuvant therapy or node-positive tumors as well. Now then, now that we have hypofractionated radiotherapy, the question is, what about centers in India that don't have 3D conformal radiotherapy, that don't have a sort of planning system? I know that these centers are less now, but in 2011 there were significant numbers. Well, the answer is, when we were recruiting in the START A and B studies back in the 1990s, the UK had very few centers which had 3D conformal radiotherapy. Breast was being treated using hand-based planning, 2D planning. And so this is a safe dose fractionation to use. However, you have to remember that you have to be a safe radiation oncologist. So you have to have a central axis dose. I mean, this is technical radiotherapy, I know, but a central axis dose which is between this and this. Now, this is not difficult to achieve. A central axis one plane dose between 95 and 205 is not difficult to achieve even in a cobalt machine with physical wedges. Right. Now that we know that we are using moderate hypofractionation safely in India, we now think about how can we improve morbidity further. Well, that brings us to the concept of organs at risk, or OAR. So our surgical colleagues will hear us talking about organs at risks in India. And as I said initially, the organs at risk include the contralateral breast, the lungs, ipsilateral and the contralateral lungs, and definitely the heart and left-sided tumors. The worry is, you can see this when we are using tangents, the apex of the heart through which the left anterior descending artery just passes through. If you remember the anatomy, it is exactly there that the high dose of radiation affects. And that led to the concept of, this was yet another real important paper that was published in New England Journal of Medicine in 2013, that even a minimal dose to the heart can affect a patient's morbidity, a cardiac morbidity. So a 7.4% increase per gray is what they postulated, and there's more to the paper than this, but in general, it's a linear curve. So even if you try and reduce a dose minimally, then it helps. Now, by minimal dose reduction, we again did a study around the same time. So about 2015, we said, okay, fine, we're using hypofractionation, but let us see what dose we're using. And we found that the dose we are using is reasonably safe in the heart. And how are we using this dose which is safe? What are we doing which is important? Let me try and share with you that. So basically, what we tend to do is we tend to use in our tangential fields, we tend to use multi-leaf collimators to collimate the beam in such a way that the heart actually is protected. So, just think of the beam coming in from this side, and these are the things that are called the collimators. They shape the beam. So you can see this collimator is shaping the beam in such a way that this blue thing, which is the heart, is protected. So the heart is protected and the beam is shaped properly. So this was the initial way that we got a very significant low dose. So a mean heart dose was low, and we said that yes, what we are doing is very, very good and in keeping with international practice. And we again presented this data in ESTRO. What is important, and this is something I'd really like to share with you, in the study that we did, what we found is that it does not have to be a 3D conformal radiotherapy planning all the time. So in a lung cancer, in a lung, when we are trying to spare the dose to the lung, if you even have a less wide tangent, which is less wide by 5 millimeters, you have a significant reduction in dose. So basically the outcome was, if you have a 2 millimeter block by using an MLC to the heart, so if you can shape the beam with micro MLCs, and if you have at least a 2 millimeter block, the mean heart dose comes down significantly, and we're talking about statistical significance here. And also, if you have a sort of your wide tangents, which are at least 5 millimeter tight, then you can actually get less dose to the lungs. So that brings us to the reduction in morbidity using heart and reducing heart and lung dose. And then we come on to the respiratory gating for heart lung cancer. So with progress, we tend to we started commissioning inspiratory breath hold techniques. So you can see over here, if one breathes, the heart pushes back and comes medially, thereby the tangents miss the apex of the heart. So the heart moves up, pushes back, and comes medially. That's why the tangents affect less of the heart and less of the anterior descending artery. The question is this cost effective? We are from a trust hospital, so we are commissioning something. It has to be something that is not only helping patients in general, but also, or helping patient individually, but also helping patients in general. So that's the cost effectiveness. So we did a cost effective study, and I must thank Dr. Shantam Chakravarti, my colleague, who did a lot of work on the cost effectiveness using the ischemic heart disease data from the Indian Cardiac Association database. And we found that just a 3.5 hours extra person hours. So over a 15 fraction treatment, it is just a 3.5 extra person hours that's required to try and reduce 1 gray. So you save 7.5% cardiac morbidity by just using 3.5 extra person hours. And these main extra person hours is not for doctors, they're radiation technicians, because they are using the DIBH technique every day. And this is definitely significantly cost effective to use to try and save radiation morbidity. So for centers that do not have a sort of RPM system yet, please use this paper. It was published in Practical Radiation Oncology, I think 2018. It is very important you look at the data and go to your director and say, please, can we have an RPM system? We're coming towards the end of my talk, and believe you me, we're talking about extreme hypofractionation now. That's something that you all are interested in, because there's been quite a few publications of late on extreme hypofractionation. You've got to remember certain things. When we are treating cancers, we said that breast cancers are responsive to fraction size. So if we give more dose per fraction and appropriately reduce the total dose, obviously we are likely to get a better benefit in terms of radiation or in terms of breast cancer control. But the concept is that we should not just concentrate on control, we should concentrate on normal tissue toxicities with the high dose per fraction as well. So the studies that actually looked at these are the main studies that have actually looked at the high dose per fraction. And of these, I must say, the UK studies, the FAST and the FAST Forward, are the ones that we are going to discuss in a bit more detail, because they are much bigger studies. In fact, we have the full text publication of the FAST Forward recently, which actually makes us very, very happy that there is something that we can try and do in 1 week rather than over 15 days. Okay. Now, sorry. The first results of the UK FAST study, the FAST study was actually comparing, a dose of 6 grays per fraction versus 28.5, which comes to around 5.5 grays per fraction, versus a 50 grays in 25 fraction, which was the then standard. And what it showed is that if you use 6 grays per fraction, you're actually having more toxicities although the control arms were same across the groups. So basically, this was a proof of concept phase 3 randomized control study that showed that in a select small tumors, if you treat over 5 weeks, but 1 fraction per week, you do get a significant local control. However, if you just have 2 grays extra, you do have significant toxicities. The next generation of the studies was the fast forward study, in which the then standard was the 40 gray in 15 fraction was compared to 26 and 27 gray. And I'm not going to why it was 2 arms, 26 and 27. It was to test what exactly is the sensitivity of the breast cancer and calculate what we call as the alpha beta ratio, which we're not going to talk about now. So it was testing these 3 arms, and I think I have the fast forward data over here, and it confirms that across the 3 groups, it is it is similarly efficacious, or let me be technically correct and say that none of the groups were inferior to each other in terms of tumor control. However, the 40 grays in 15 fraction arm and the 26 grays in 5 fraction arm were equally cosmetically good. So the 27 gray arm was slightly worse cosmetically. So that is why the 26 gray arm is likely to be something that's been looked at for future established practice. And the NICE, I know, is currently looking at this data to try and see if this is going to be the new standard in the UK. Now, when the fast forward results came, we sat and we said, let's see if this is the data that can change our patients' practice. 4,000 odd patients, and median age around 60 years, around 10% with triple negative breast cancer, about a third who have grade 3 tumors. Is this something that we actually can say will establish our practice in India? Just look at it. The node positive rate is just 1 in 5. It's just it's just opposite as to what we get in India, isn't it? We have 80% with node positive. Similarly, look at the grade 3. We have around 80%, 70-80% who are grade 3. The data over here says that it's 30% grade 3. Triple negative, yes, we have around 15, 20, up to 25%. Again, this rate is low. STF radiotherapy, not reported. IMN radiotherapy, not reported. Lymphovascular invasion, less. So it's possibly a different tumor group that we're looking at. And I wouldn't be that excited to change established practice yet, because the data that we have is not yet ready. And a fast forward nodal study is underway that would give us more data on whether this dose is acceptable for the higher risk population. Now, I said that I'll share with you some of the important areas that we actually looked at in setting up hypofractionation. So I shared with you how we went ahead, did the quality assurance and then the audit, and we established the 3-week regime in India. And thereafter, what we tend to do is, we tend to explore whether we can safely deliver the 5-day regime. Remember, the 5-day regime was all 3D conformal radiotherapy with proper 3D dosimetry and proper TPS-based plans or treatment planning-based plans. So these are not cobalt or simple linear accelerated treatment. These are proper field-in-field treatments. So what we tended to do is we said, okay, when we are using something which is a significant dose per fraction, why don't we do something called a HyPort A study? So we selected locally advanced inoperable breast cancer patients, and we had some intramural fund where we said, why don't we try and do a 2-week regime first and see if these breast cancers who need palliative radiotherapy actually do benefit and have a lot of, and don't have many side effects if we use a 2-week regime rather than a 3-week regime. This was way back in 2015 that we conceived this study. And lo and behold, we were really happy when the results came through. And these are the dosimetry that we did. And you can see this is how the tumors were treated using big tangents. And this is the dosimetry conform. So we approved the doses only if we met these criteria. And we can see that there was a significant shrinkage, ulceration healed. There were no patients who complained of significant toxicities just because of the radiation. So one of the benefits that we had is, yes, one of the benefits that we showed is, yes, locally advanced cancers, we definitely tend to get a benefit in terms of symptomatic control. And what was a bonus for us is that we found that it is very well tolerated, a regime that is tolerated in our Indian patients. So this was the 2-week regime. Well, whilst the 2-week regime was being built, we started developing something called a simultaneous integrated boost. Now, remember I told you that, after breast conservation surgery, in the adjuvant setting, not in the locally advanced palliative setting, in the adjuvant setting, we tend to boost them after breast conservation surgery. If we don't boost, there's going to be about a third, 35% of cases would have an in-breast tumor recurrence. What if within the whole breast radiotherapy treatment, we can simultaneously boost the tumor? So if we treat the whole breast to a particular dose and simultaneously boost the tumor, so basically the whole breast is getting 40 grays in 15 fraction, but simultaneously we're giving 48 grays to the tumor bed. Well, there have been multiple randomized control trials, 2 of which are seminal, especially the import high study, which was being conducted in the UK while we were actually getting our class solution done in Tata Medical Center. And we showed that using simultaneous integrated boost, using a hybrid VMAT technique. Now, this is now getting more and more technical, pardon me, but what we tend to use is basically, it was a forward plan technique, basically a simple technique for using tangents for the whole breast, and then integrating that with what we called as a hybrid partial arc, so medial and lateral arcs using an inverse plan technique. It is one plan, so a patient every time is delivered one plan, whereby part of the treatment is delivered using a forward plan, part of the treatment is delivered using an inverse plan. You can see the red line over here. The basic concept still remains the same, that my mini tangent that I'm using to boost this should not affect more of my lungs. So there should not be leakage, there should not be divergence. More of my lungs should not get affected. So that is how we commissioned the class solution for the simultaneous integrated boost. Now we have to implement it. How can we implement it? Again, we said, look, we want to implement a 5-fraction radiotherapy schedule in the adjuvant setting. Prior to that, let's implement it in the locally advanced inoperable population. And we have done this now in all 30, in this phase 1, phase 2 study, whereby we have now successfully treated these patients using a simultaneous integrated boost. And the data actually shows that significant patients, it is actually a 30 patient, this is old data, we now have completed recruitment in the study, and there's a significant improvement in the fungation, in bleeding, in pain scores, and none of the patient had grade 3 toxicities, which just proved that the simultaneous integrated boost is likely to be well tolerated. And these are big tumors that we are treating, is likely to be well tolerated in the smaller tumors in the adjuvant setting. Well, you must have seen that we've done PET CTs pre and post, both for the 2-week as well as the 1-week study, and we are using a radiomic study now to try and see if there are any PET CT radiomic signature to try and predict tumor response. Like I said, whilst we were doing all this, the UK team, which was way ahead of us in India, had started an adjuvant therapy study of concomitant boost using 48 grays in 15 fraction rather than the sequential 16 gray boost. And the second test arm they had was using a 53 gray arm. And what the results and import high results are now out, presented in San Antonio last year, it showed that the 48 gray simultaneous integrated boost is similar in efficacy to the 40 grays sequential boost. So 48 grays in 15 fractions simultaneously treated, so then extra 2.5 weeks of travel for just the boost is now reduced. So 48 gray is good enough if in 15 fraction, if you can have the class solution for it. And the disease control was similar, the morbidity was similar. However, they showed that if you give too much dose, again, if you give 53 grays, then you tend to have more toxicities. Now, the last few slides, promise you. This is something that I'm tremendously proud of to share with you. We in India have not commissioned a randomized controlled trial. Tata Medical Center has had the privilege of working with colleagues from Christian Medical College, Vellore, SGPGI Lucknow, All India Institute, New Delhi, as the 3 centers. So one from the north, one from the south, from one from the north, well, 2 from the north, 1 from the south, and Tata Medical Center from the east. In that, we have now started recruiting in one randomized controlled trial that is actually testing a simultaneous integrated boost dose and a 5-fraction regime. So basically what I'm saying is the control arm of the study is treating over 3 weeks, 40 grays in 15 fractions or 48 grays in 15 fractions, whilst the intervention arm of the study is a genuine 5-fraction regime, even in patients who have breast conservation, because we are using a simultaneous integrated boost of 32 grays in 5 fractions, rather, there you go, 32 grays in 5 fractions SIB, whilst you have 48 grays in 5 fractions, or 15 fraction as the standard arm. Now, the study has already recruited more than 500 patients, and we believe that we are going to complete accrual within the period that we have stipulated. And you might ask as to why more centers are not being allowed in. Well, we want a robust quality assurance. We have a international data safety monitoring committee, and we are now thinking of taking more centers in for the study, but they have to abide by quality assurance, because we want this to be an India specific study. Next, this is the eligibility criteria, which is pretty standard, and these are the endpoints of the study, and that's how I would like to finish. We are coming to 9:30. These are the acknowledgements that I have. Thank you very, very much. And I have loads. Like I said, I can talk on this for the rest of the night. I have data on the Z11 and how we shouldn't or we should take it. I have data on how target should or shouldn't be approached. But I think we keep it at this, especially for the students to digest what we've just discussed. Thank you. Over to you, team.
Thank you, sir. Thank you so much. Dr. Vinita, please take over. Yeah, thank you.
So thank you, Dr. Sanjoy. Really enjoyed your concise presentation. I think you covered almost every important study and meta-analysis of radiation therapy for breast cancer. It was quite interesting, and I think you made it very simplified, so that all the surgeons and radiation oncologists in the audience can understand it. But I must say that towards the end, when you were talking about hybrid plans and VMAT and hypo-RT, you did made it a little technical, which I think is a good idea. You must leave surgeons little confused sometimes. Yeah, and they must think that, oh, these radiation oncologists do a great job, So I think that's a good idea. I must compliment you. Geeta, you want to add something?
Yeah, so that's so I lost the plot at the end of it all, because I said this is getting to be too technical, but I'm sure those people who are studying radiation, for them these are very exciting times.
Right.
So the trainees, I'm sure, and Sanjoy, you managed to hold 50 people consistently throughout your talk. Nobody left till the time you almost towards the last 3 or 4 minutes. That is when some students left, but everybody has been all ears and just listening to you very in rapt attention. So now we'll just carry on with the questions which are there in the chat box. Dr.
So I will request everyone to put in any questions if they have. There are a few questions which are already there in the chat box. So Sanjay, we'll start with them. So Dr. Nidhi Agarwal has basically asked 2 questions. She's asking what should be the minimum dose to ipsilateral lung for a breast cancer radiation therapy plan. If you want to answer that, otherwise I would like to slightly reframe it, and I would like to ask it as what is the maximum acceptable dose, or what are the DIBH parameters that you generally look into while accepting a breast cancer plan?
Vinita and team, I want to just say that I made it simple so that I understand what I'm talking about.
Yeah, I know.
And when I mentioned about the complex plan, my brain was also starting to get fried, So I also didn't understand much of it. Anyway, talking about the dose to the ipsilateral lung, this is a question that is very, very commonly asked. And when you're using fractionated radiotherapy using moderate hypofractionation, I would say the dose to the ipsilateral lung is as low as reasonably possible. It should not be a dose constraint that you prescribe. However, of course, we look at the V5s. So a V5 of less than 5%, 10% is something that we can look at. I can share with you the protocol that we follow in Tata Medical Center. There are optimal doses, and especially for the hypoadjuvant study, there are optimal doses and there are mandatory doses. So we can share those with you, Vinita, and then you can share it with Dr.
So for everyone's understandings, Sanjoy, I would like to ask you, why are we so much concerned about doses to contralateral lung or contralateral breast or thyroid or esophagus while we are planning radiation therapy for breast cancer? Recently, I had a colleague who asked me, why are you so much bothered about the contralateral lung and breast doses? Maybe you can answer it for everyone's benefit.
Vinita, that's a Viva question. Thank you very much. So it's a question that we tend to ask our colleagues, our students in the Viva. Well, look, we are treating, some of our patients won't need radiotherapy and will be well for the rest of their lives with what Geeta and company do. We are treating someone when we don't know whether this person has got any residual cancer or not. So the rule of thumb is that do no harm in radiotherapy. So what is the harm that radiation can do? We all know that radiation, especially if we treat and wait for a longer time, in breast cancer, we are lucky that, recurrences often don't happen for a long time. If you keep waiting, then basically there can be suboptimal or sublethal damage to some of these tissues. So contralateral lung, getting a dose, is likely to develop lung cancer. Contralateral breast, getting a dose, is likely to develop breast cancer. And imagine if this poor lady who you've treated for nothing, maybe wouldn't have benefited much from breast cancer or radiotherapy at all, comes back with a lung cancer or breast cancer sometime later. Would you be able to spare yourself? I'll feel so bad. So basic rule of thumb is that do no harm, treat only what you have to treat. And for breast cancer radiotherapy, please use inverse plan treatment, which has leakage to the contralateral lung and the contralateral breast, only when you have to. Don't use it routinely. That's what we would do.
Okay. Thank you so much, Sanjay. Dr. Nidhi Agrawal has asked another question. How much of lung has to be covered in contouring? Ipsilateral lung, how much of it has to be covered in contouring?
We would not contour we would not sort of cover the lung in the contouring at all. We would contour the lung just to try and see what we can prevent, not what we can cover. I think what you're trying to say, Dr. Agarwal, is that when we're using forward plan techniques, we often tend to have a bit of lung in our tangential field. What you're trying to ask, if I'm not wrong, is, what is the minimum amount of lung that you would like to have such that you don't have a geographical miss? Now, Geeta, this is getting a bit technical, I know. But what is when someone breathes in and out, the beam can, if you are very tight on the beam, when someone's taking a deep breath out, then basically some of the chest wall may not be treated at all. So that is why there has to be some flash anteriorly. Some of the beam is going through the air anteriorly, and some flash posteriorly, which is going through the lung posteriorly. So what we tend to meter as a cutoff, but if you've got a very small tumor, if you're confident, I'm pretty sure, and your patient is in DIBH, you can even go with 0.5 centimeter, not an issue.
Yeah. So Dr. Debanjan Kundu, in the same context, has written that CLD, central lung distance of less than 3 centimeter for ipsilateral lung. So Sanjay, you agree with that? So this is the upper limit.
I would actually be a bit more conservative on that. So we don't approve plans which have a central lung distance of more than 2 centimeters. I must say that, if there's, like I explained to you, if the central lung distance comes down even by 0.5 centimeter, that's a significant dosimetric advantage.
Right. You did mention that. Sanjay, Dr. Prashant Gupta has a question that what is the ideal time of whole breast radiation therapy after surgery, and when should boost be given?
Right. So, doctor, the randomized controlled trials actually allowed patients to come in within 6 to 8 weeks. That's the ideal time after systemic therapy or after surgery. And in terms of the second part of the question was
when should boost be given? When should boost be given?
So, it is sequentially. You have a very advanced setup. and you have commissioned a class solution for simultaneous integrated boost with which is
Sanjoy, we've lost you. We've lost you now. Dr. Sanjoy?
Yeah, we've lost it.
Yeah.
Right, Vinita. Any other questions? Anything else we can help you with?
Sanjoy, we lost you for some time. So I think we missed the answer to the last question. When should boost be given?
So,
You were not
Vinita,
audible for some time.
it is like I said, it is usually sequential boost. So after you finish the whole breast radiotherapy, or if you have a very advanced center that is actually looking at simultaneous integrated boost, which has been safely commissioned within a class solution, then you can think of doing that.
Okay. Couple of more questions for you, Dr. Sanjoy. One is that in case there is a triple negative breast cancer, patient has undergone mastectomy and it is a node negative breast cancer. So which are those T1, T2, N0 triple negative breast cancer? Do you ever consider them for radiation therapy? You know, outside clinical trials. What I mean is in routine practice.
I should have actually had a slide on this. We actually tend to do that. So basically, you know, I mentioned that, you know, lymphovascular invasion, tumor size, they all play a significant role. So what we tend to follow is what is called as a Cambridge score index. So a Cambridge score index talks about the grade of tumor. It talks about whether there's any lymphovascular invasion and whether there is what is the margin of the tumor. So these three are looked at. So if we find that the score comes to 3 or above, we tend to give radiotherapy even in the node negative post-mastectomy patients. And we've published our data again on that, which shows that it actually is in keeping with the international published Cambridge score index paper, and the local recurrence is very, very low.
Another situation, Dr. Sanjoy, if there is a patient who had a T3N0 disease to begin with, received NACT and undergoes mastectomy later on and has a PAT CR, would you consider post-mastectomy radiation therapy for these patients or not?
Yeah, I mean, this is a good question. Whoever's sort of asked this question has done a lot of work in that, you know, there are recent publications in the literature which talks about omitting radiotherapy in patients with who have a complete clinical response. However, I must say that, you know, we tend to be very conservative, and especially because of the fact that, you know, when there is a T3 tumor, although the patient has had a complete response, there's no level 1 evidence that suggests that not offering radiotherapy is going to be safe. So we tend to treat them.
Another situation sometimes that we face is an elderly lady, say around 70, 75 years old with early breast cancer, post breast conservation surgery, good profile, ERPR strongly positive, HER2/neu negative, low Chi labeling index. Would you spare these patients of radiation therapy and just put them on hormonal therapy, or would you consider hypofractionated breast RT or APPI? I mean, some kind of radiation therapy versus no radiation therapy for them.
So, you know, the bottom line is we hypofractionate all our patients. That's number one. So so being old or being young doesn't really, I said that, you know, hypofractionation is higher dose per fraction. So it's breast cancer. We need to give higher dose per fraction. That's number one. Number two is whether to treat or not. That's a very good question. So, you know, in a luminal A-type tumor, whether we would like to really treat that patient or not. Now, if you look at the PRIME 2 results, which is a randomized controlled trial that has been published about a couple of years back, it showed that even in these group of patients, if you treat, you do have a 2% benefit in terms of local control. However, in the luminal A tumors, the benefit is least. So the current consensus could well be that in patients who have grade 1, grade 2 node negative T1 disease, you can actually omit the radiotherapy in them if they are elderly. However, those patient groups are very low in our country. We have younger patients, and we do have a huge node positive tumors. So as a policy, we've not taken this as not radiotherapy, but yes, in a case-by-case basis, we can think about it.
Another situation that we are facing in the COVID times is that, you know, a lot of patients are coming late for radiation therapy. During lockdown, they completed their systemic treatment. So how long after starting of, say, surgical treatment, would you consider them for radiation therapy? Somebody who got operated 10 months back and comes to you due to COVID situation, could not come earlier and now comes to you after 10 months, would you give them radiation therapy, or what is your upper limit?
Vinita, this is a very difficult situation. Yeah. I mean, all of us are facing this, isn't it? Patients are not coming through. When they're coming, they're asking for it. So, I have a heart-to-heart conversation with them, saying that the evidence is pretty lacking. And then I also say that, this is the benefit of having radiotherapy. If someone has a very high risk disease, I tend to sort of offer them radiotherapy at that time. If someone has a very low risk disease, I tend to tell them that, look, I really don't think the absolute benefit of radiotherapy in you at this time is going to be significant. But even then, if you choose to have it, knowing that, these are the side effects and benefit, you can have it. So there's no evidence for it. These are a clinician's job to discuss the pros and cons and decide.
Very well said. So Dr. Nidhi Agrawal is asking another question. Are there any indications where boost should not be given after breast conservation surgery?
Yeah, Dr. Agrawal, your question is very valid. In fact, you know what? In the West, in the UK, boost is not given in patients who are more than 55 years old, because they have screen detected tumors, small tumors, and and if you look at the Bartling paper with the if I can go back to the anyway, I mean, I'm going to just talk to you about it. Basically, the points that we have to look at is age of the patient. We have to look at whether there's any DCIS associated with the tumor. If the age is more than 55, 60, if there's no DCIS associated with the tumor, if the patient is otherwise fit and well, they would usually avoid. However, in India, we have a lot of grade 3 tumors. We have tumors that are, and so in breast cancer, sort of grade by itself predicts local recurrence. And you can see the Bartling paper again. There's a trend towards local control benefit in the grade 3 tumors. So majority of our patients do get boost. I don't remember not boosting a patient after breast conservation surgery, but in an isolated case, again, if there's a problem, you may avoid in those indications.
Dr. Navneet is asking a question. His question is that when do you give radiation to axilla? For example, suppose you have a patient with where axillary nodes have extra nodal extension. Would you consider axillary radiation in an adequately dissected axilla for these patients?
Yeah, Dr. Navneet, thank you for asking this question. Let me make one thing very clear.
Hello, Dr. Sanjoy?
Hi, can you hear me?
Yes, we can hear you. We can hear you, sir.
Dr. Sanjoy?
Dr. Vinita, he's audible.
Am I audible? Shall I continue?
Yes, please. Yes.
Okay. So, Dr. Navneet, the question of treating the axilla does not arise after axilla is addressed by the surgeon. So extracapsular spread, as we know in head and neck cancer, if there's extracapsular spread, giving radiotherapy, especially chemoradiotherapy, does help. It is not the same in breast cancer. Extracapsular spread in the axilla in breast cancer means that the patient has a higher risk of systemic recurrence rather than if you give radiotherapy per se. If your surgeon is someone who you trust, which I trust, if a surgeon is there like Rosina and my colleagues in Tata Medical Center, like Geeta, I'm pretty sure I won't have to think twice that the axilla is appropriately dealt with. And I would only address the axilla if the surgeon has not touched the axilla.
So, Dr. Naveed, Dr. Nidhi, I believe that your questions are answered well. If there are any other questions, then we'll take them. Otherwise, I'm sure everyone is tired and we'll close the session here.
Feeling hungry.
Feeling hungry. Sanjoy, thank you so much. Thank you so much for being there and for patiently, presenting so much of data at the fag end of the day and answering so many questions. We really enjoyed your presentation. Thank you so much. Geeta?
Sanjoy, you should be making yourself more available to, this is a great time to be in, so, it's a good thing to, share your depth of knowledge with all these kids, who will grow up to be excellent radiation oncologists. This is what I believe because,
Geeta, once I know, I will share. So, let me learn a bit more and I will be looking forward to sharing with you.
Being very modest, but yes.
Thank you.
Yeah,
Thank you.
done
So
a great
just one thing that I noticed, and this is for Dr. Geeta and Vinita and Dr. Sanjoy, that, when Dr. Sanjoy said that if there is PATH CR after NACT and we do a mastectomy, they would be conservative and would go for radiation. You know, you will be treating and you would still call yourself conservative. But if, for me as a surgeon, if somebody tells me that there is no tumor and I ask them to that I will operate, they will tell me that I'm aggressive, not conservative. So
Can I answer your question, Dr. Garg?
Yes, sir. Please, I was actually waiting to hear that. Yes, yes.
So Dr. Garg, when you don't have a cancer and you do cancer surgery, you know,
Yes.
people will take you to jail. Whilst when we are treating someone post your treatment and post neoadjuvant therapy, people leave us. It's mainly because they feel that, you know, as radiation oncologists, we practice evidence-based medicine.
No, I agree to it. My question was to, is our aggressiveness wrong or your conservativeness is the right?
Yeah, I think, you know, your question is superb because none of us know what to do in these cases, isn't it?
Yes,
We tend
It's
to
a gray
treat.
zone.
Yes, we're treating. I think, you know, we even in patients, if we don't treat, I think most of these patients will be well. Yeah. I don't know. I mean, we need more data on it. But yeah, thank you for bringing this question up. Yeah.
Thank you. I think I was making head and tail of radiation, and I think you made it very very surgeon friendly, because there was times when you said that this is for my surgeon colleagues, and I would sit up and listen to it, and I said, yes, I know, and I can tell Dr. Vinita that I know some radiation. But like Dr. Geeta said, you had the last word with all that VMAT and stuff coming in. But thank you, sir. I think it made a lot interesting for us. I'm sure we will open up breast radiation with APBI and this in the coming weeks. And thank you so much for joining in. Dr. Geeta, last comments?
Thank you again. Thank you, Sanjoy and Vinita. You know, having two supremely educated people, this is what I think, and I know I'm right. You know, so it's been wonderful. And you know, this particular lecture goes on to our YouTube archive, and I'm sure a lot of people who don't know Sanjoy, because Sanjoy has decided to stay out of this, because there are a lot of students. You know, students are getting introduced to the best faculty in the country. So once they see that this is this person who speaks so well and so clearly, I'm sure there'll be a lot of views on your YouTube video also from tomorrow onwards, or probably soon after we finish, because I'm sure the kids who were here would share it with those colleagues who were not able to hear this. But fortunately, we're able to archive this for the benefit of larger number of students. So great day. I've enjoyed it thoroughly, and we will meet again for all the students who are still there. Next time, same time, Wednesday, 8:30 p.m. We're not leaving a topic just now, because we're just in the process of finalizing it.
Okay.
Thank you so much.
Thank you so much. Thank you.
Thank you.
Thank you for the invitation.
Good night.